diagnosis that a provider puts into the office note may immediately trigger a down code from the payer.
I've seen prior authorization delay care for my patients, and that's been very unfortunate because our patients are usually when they come to our clinic, they come with a lot of pain, or they could have some neurologic deficits, or they could have something called myelopathy, all symptoms that require further, advanced imaging and testing for us to know how to treat. Think about the most frustrating experience you've ever had with a call center.
Welcome everyone, I'm Zach Ruhl. I am the CEO at Maia, and today we're talking about one of the biggest risks in healthcare revenue cycle, prior authorization. With prior authorization issues, even perfectly performed and perfectly coded cases can still get denied when your authorization doesn't exactly match the procedure codes that you performed. I'm joined today by two wonderful surgeons, Dr. Michael Rohmiller and Dr. Hao-Hua Wu, who have both seen firsthand how prior authorization breakdowns can create denials, delays, underpayments, administrative friction, and frustration for physicians and staff. In this session, we will discuss where the current process breaks down, go over real-world examples of how these issues impact their practices, and discuss what the future could look like as it relates to prior authorization to improve how practices handle this process. Thank you for joining me, Dr. Rohmiller and Dr. Wu.
Morning.
Dr. Rohmiller, I'll call on you first. I am curious, in your career, how you've seen prior authorization change over the years and how you've seen it impact your practice.
Well, I think what we have noticed is the payers have become more sophisticated in their requirements, in their reviews, and in their ability to deny or even downcode charges that would be submitted. So I think the one thing that we have seen is that you have to be very intentional in your coding, or else you'll have problems on the back end with your reimbursement and collections.
Interesting. Has that had a material impact on the top and bottom line at your group?
Well, it definitely has. And so I think one of the current buzzwords has been downcoding. And I think that's something we all talk about. And so if you're talking about an office visit or an E&M code, one of the things we've found is that the diagnosis that a provider puts into the office note may immediately trigger a downcode from the payer. In many cases, the provider doesn't even know this. So what may have been used in spine surgery in the past is, I saw a patient for the first time, they have low back pain. Well, many providers will see low back pain and immediately downcode. You may have satisfied all the requirements for a level 4 or even a level 5 office encounter, but they're going to downcode you simply because of your diagnosis that was submitted as an ICD-10. So I think that's one of the things we've learned in our practice.
Awesome. Thank you for sharing. Dr. Wu, given that you're 3 or 4 years into your practice, how have you dealt with prior authorization as you've gotten up and running?
Yeah, I think the biggest challenge really is that I've seen prior authorization delay care for my patients, and that's been very unfortunate because our patients are usually when they come to our clinic, they come with a lot of pain, or they could have some neurologic deficits, or they could have something called myelopathy, all symptoms that require further, advanced imaging and testing for us to know how to treat. And one of the most common things that I get asked for from a prior authorization standpoint is to do a peer-to-peer for insurance companies to ask us if the MRI I've ordered or the treatment I've ordered is the right one. And that's very frustrating. It takes a lot of time from us as clinicians to do so, but it ultimately delays the care that we can provide our patients.
Yeah, that is that's a serious impact when you're talking delay of patient care. Does that require additional time from you as well?
Oh, absolutely. It's to the point where I think that I have to have some time, at least once a month, where I can sit down and make calls. And when you make these calls, it's not as simple as calling a number and someone picks up and you talk to them. You call, you get put on hold, they reroute you to someone else. Think about the most frustrating experience you've ever had with a call center. That's what we have to do every time we want an MRI for one of our patients.
Interesting. And that's you personally doing that call.
Yes, that's me personally calling.
Dr. Rohmiller, as you've seen changes over the last, let's say 5 to 10 years as technology advanced, how do you think prior authorization will change as we move into the future? As you mentioned, payers change their policies, technology advances. What do you think the future looks like?
Well, I'll give you what I would love to have as my dream scenario. So the dream scenario is that the codes submitted for a prior authorization match what is performed in the encounter and are then also matched with what is billed and subsequently reimbursed. So to kind of get a little bit more granular with that, the idea would be I see a patient, I develop a plan of care, a system, hopefully something AI based, such as Maya, would then come in and comb through my note, find codes that would be appropriate, submit those to the payer, receive the authorization. I then, in this case, perform surgery. The codes are again combed through, submitted. They are indeed accurate and reconcile with what I submitted on the front end. It's billed. Then we are receiving the collections back. And again, there is a system that confirms front end, back end, and collections all dovetail together. That's the ideal scenario for any provider and certainly would eliminate a lot of wasted time, in addition to a lot of wasted resources in filing retro authorizations if what we submit on the front end does not completely agree with the back end.
I was talking with a practice 2 weeks ago, and their thought was that every time their surgeons leave the OR, they would be locked in until they triggered a retro authorization if needed, based on what they just performed in the OR and what was pre-authorized. What do you think about that, being locked in to your OR until you submit it?
Well, again, highly inefficient, would be a complete waste of your most expensive resource, which is the provider's time.
Right.
But it's not unreasonable in the standpoint that you have such a short window after the case is completed and the code is submitted to file a retro authorization. Again, this is all a system that's been designed to, I'm not going to say penalize, but to enforce very strict adherence to what is required. So if you change something, which again, we all try not to, you have your plan, you go in, you execute that. If you change anything, it has to have a retro authorization. I give the example in my own practice. I looked at what we submitted and then what was ultimately billed, and the case didn't change. It's just the person who submitted on the front end and the person filing the actual bill on the back end were two different people. They had different views. 30% of the time, through no fault of, I guess, anyone's, we had a difference in those codes. And again, that's an immediate trigger for the need to file a retro authorization. That's wasted time. That's inefficient. But again, it's trying to play by the rules.
Yep, exactly. And the rules are constantly changing, it seems to, and they're different based on each of the insurance companies or the government payers that you're using. Dr. Wu, curious what you think as it relates to the future of prior authorization and how technology can impact your processes.
Yeah, I think the biggest thing, and I agree with everything Dr. Rohmiller just said, the biggest thing that I see is that it saves time but it also allows us as providers to be more efficient and diligent with our patient care. Like, you don't want us to be spending our time having to figure out the codes. You want us to focus on making the right diagnosis, advocating for our patients, spending all of our energy, our mental capacity to doing a great surgery if need be. The coding should be an afterthought. That's one of the reasons why I got in academics. My whole goal is to take great care of my patients. But, if we have a tool that can allow us to be more efficient, like Dr. Rohmiller had said, Maia is one of those tools. That would allow us to be better doctors for our patients to get better care.
Yeah, I agree with that. I think as we look at technology impacting healthcare, especially the healthcare revenue cycle and administrative processes, we want to enable doctors to focus on their patients, right? And so much of a doctor's time today is spent on administrative tasks like coding and reauthorization and denial appeals and collections and documentation and these aspects that are very important operationally and impact their entire practice, but are not as relevant to the patient care process, right? And we as a society, in my opinion, want our doctors to be 100% focused on their patients and improving the outcomes of those patients.
Yeah, you want us to be present. When you walk into the clinic, you want us to be present and focused on you, not on the insurance company.
Yes, absolutely. And I have experienced the opposite. Even in the recent past, we had some procedures done for a family member, and you feel it when you're talking with the doctor, the administrators. It disrupts the whole process. We specifically had the prior authorization delay a scheduled surgery while we were in the hospital by a week. So we had to leave. We were there, ready for the procedure, left, had to come back a week later to have the procedure done. And so we're experiencing it firsthand, that it's not only impacting your time, it's your patients and the quality of care that they're receiving. Thank you both for joining, Dr. Rohmiller and Dr. Wu. I think a big takeaway from today's discussion is that prior authorization is a critical function to any healthcare practice right now, especially in the orthopedic space and especially in spine surgery, as you both are spine surgeons, because that need for retro authorization is not rare. That's coming at a significant amount of your cases. And then small disconnects in the revenue cycle and prior authorization process can lead to disruptions in patient care, to additional demands on your time and your administrative support's time, and increases the overall friction of the process. And as we look forward, I am hoping and expecting that technology can help remove some of that friction and can increase the speed and the effectiveness of your processes, such that you can then go in front of your patients and focus 100% on them and spend your time and mental effort improving their outcomes and improving the quality of life for your patients and for yourself and your administrative team as a whole. Thank you for joining.